Good afternoon, and thank you for attending the STN monthly webinar. This session is being recorded so that it can be offered as on-demand CE for our members. Your lines are muted, but if you have any questions during today's presentation, please type them into the question queue on the control panel, and we will address them at the end of the presentation, time permitting. The presentation is also attached in the handout section of the control panel. STN is an accredited provider of continuing nursing education. To claim CE for this session, you must attend the entire session and complete the online evaluation of the presentation. If you are attending this live session, you will receive an additional email about 1 hour after the event with directions to complete the evaluation. Certificates will be emailed approximately 7 to 14 days after today's event. If you are viewing this session as on-demand CE, you'll be able to download your certificate after completing the quiz and the evaluation. We hope that you gain great value from our educational session. Today's speaker is Natasha Lukasiewich. Natasha is currently a clinical nurse educator and legal nurse consultant. Throughout her years of experience, she has 15 years in the healthcare industry. She initially started off with her holistic health practitioner diploma from Grant McEwen University in Edmonton, Alberta, Canada. She later got accepted into the accelerated track nursing program at the same university. Currently, she is halfway through her master's in science of nursing through Capella University. Emergency medicine and critical care has been her passion. Natasha has taken care of critical patients in the skies as a flight nurse in Central Coast, California to the Sierras and the rural Nevada deserts. Natasha is a humanitarian at heart and loves advocating for her fellow colleagues and patients. In 2014, she was awarded Critical Care Nurse of the Year for Northern Nevada's Nurses of Achievements. She was recognized for her efforts in pioneering and bringing advanced medical care to the Washoe County Sheriff's Hasty Team. She is actively involved with the team, extending her focus to the critical response team and peer support. In 2015, she was nominated for the Emergency Nurse of the Year. In 2016, Natasha presented this topic at the Emergency Nurses Association Conference. Being a child survivor of a parent who died by suicide, it has been her lifelong journey in creating suicide awareness. It has been her honor to be a voice for others who cannot speak. Please welcome Natasha.
Thank you so much, Cody. I appreciate that wonderful introduction. And thank you to everybody who's here this morning, or it might be afternoon time or getting lunchtime for you. So we will be talking about some pretty good, heavy subjects. So if there are triggers, stay on the line and we can deal with that, or I can get you resources. But the goal of this is basically we want to create some awareness, and we have so much focus on taking care of our patients, but how are we supposed to do that if we don't have the right balance in our own lives? So I'm going to go ahead and we're going to talk about Heroes Are Human Too, exploring depression, PTSD, and suicide among our healthcare responders. So we always have learning outcomes anytime you have the availability to get CEs. So the goal today is we also want to just kind of touch on the human psyche in regards to depression, kind of define what acute stress disorder and post-traumatic stress is, and suicide. We want to be able to have a greater suicide awareness, to take care of either someone we know or have awareness within our own mental health. We want to reduce the stigma of mental health. We want to check in with the alarming statistics that are going on. And I've kind of developed a 4-step guide of how we can help one another and look out for each other. And also we'll touch on some resources available, because there's a lot out there that I don't think we're all aware of. And definitely we always want to touch on the ethical and legal implications of mental illness when it comes to taking care of our patients. So I don't have any conflicts of interest. I have no sponsorship for this presentation. I have basically taken this upon myself and have a lot of support in being a voice for others and just talking about some pretty hard, subjects to talk about and trying to normalize it. Currently I'm an educator with Barton Health up here in South Lake Tahoe, and I also do legal nurse consulting on the side. So both those emails you can have access and ask me questions later if we don't get to the end today. So just for the sake of defining, when I talk about healthcare responders, I want to use that word just to define all of us, whether you're a nurse, doctor, a respiratory therapist, involved in EMS, law enforcement, firefighters, chaplains, social workers, people who do language access services, anybody that can witness or has contact, whether it's indirectly or directly with our patients, you are a healthcare responder in some way or another. So let's just talk about revealing the layers. So when I first started in the healthcare field, I actually received my diploma as a holistic health practitioner up in Canada. And when I was learning about how to address the wholeness of the patient or the client, you know, it was explained to me that we are like onions. And at first I was kind of like, we're comparing ourselves to vegetables, but it really is a good analogy that we have all of these layers that are built around us. And we always have this superficial, you know, there's a facade that we all carry, but as you go deeper and deeper, we're more potent. And so anytime we experience trauma, whether that's a physical, emotional, psychological, whatever that be, that affects the outer layers of who we are. And so if that trauma isn't dealt with, and, you know, it's normal to have, you know, sadness and anxiety and, you know, reactions to that, that's a normal experience. But if we don't take care of that and take care of ourselves, it can lead to, you know, things like depression, post-traumatic stress, and if those things are not taken care of, then, you know, people might start having suicidal ideations or even act on it if they don't receive the proper help. So just kind of want to use that as a visual context for everyone out there. So a lot of us probably have some sort of medical background. I'm not going to go into defining what depression is, but as you see on your screen there, there's, you know, some bullet points as a reminder of what depression is, and it varies in different degrees. You know, everybody can experience some sort of sadness. When it becomes an issue is when it's basically going to interfere with your daily activities of life. So if you start noticing, you know, that you can't get out of that deep mood, you're having problems sleeping at night, have that insomnia, you're not eating or you're overeating, which is not a normal habit of yourself, you're having restlessness or fatigue or loss of energy, even making decisions can be a sign of depression. And a lot of times you don't notice it yourself. It's the people around you, usually the ones that are with you all the time. So if someone makes a comment to you of, you know, something's up and you're not acting yourself, that is kind of one of those little, you know, white flags, yellow flags that can go up of like, you know what, I need to check in with myself. So a lot of people have not actually heard of acute stress disorder, and this is something Australia actually utilizes a lot in their language. Acute stress disorder is actually something that can occur in 1 month of an event that you happen to see, witness, be a part of. And usually, you know, that's something that goes away, and that's a normal reaction to an unfortunate circumstance or a critical incident stress situation. And you might start noticing that you have some sort of, they call them dissociative symptoms, and basically that's, you know, you kind of have this numbness going on, you depersonalize things, you know, because we're really good at having those coping mechanisms, and so that we don't get drawn in with our empathy and trying to take that stuff home, your body goes into this defense mechanism. So you might even start forgetting about things. I know I was just having this conversation with my husband not too long ago that, you know, we were talking about certain calls and flying, and he mentioned an area in rural Nevada. I'm like, oh, I totally forgot about that area. And of course, you know, that started bringing up some of the calls that I had been on there, and they weren't the most successful calls. So just know that it can occur, it can go away, but it also can be a predictor of post-traumatic stress disorder. Now you'll see on the right of my screen there that it says PTSD or PTS, and I really want to try, and I'm a big focus on like linguistics. So if we take away the D and talk about just post-traumatic stress, it's almost like people can embrace that. It's all about the linguistics. And you'll probably start seeing a lot of the mental health community starting to drop the D so that it's not a disorder, it's an actual reaction to something. So a lot of people, they also associate PTSD or PTS with veterans. You know, that's where it was getting a lot of the names. But it's actually quite current and common in our healthcare industry. So when we talk about intrusive memories, those are things like, you know, recalling the calls that have been occurring. You know, you'll have these flashbacks. You'll be driving and you won't be in the here and the now. You kind of realize, how did I get to point A from point B, or vice versa, point A to point B. You have these memories that are coming in. And then avoidance behaviors is, say, a great example is, say if you're working in EMS as a pre-hospital and you get a page out for a certain call, and that might be a trigger for you, and you're telling your partner, you're like, oh, I don't know if I can do this call. Those are avoidance behaviors, or avoiding going by, a certain road that something happened. Or you could just even be, a nurse driving home from your shift, and at one time and one point in your career, you rendered aid, and you're having that, intrusive memories and flashbacks, and so you might avoid driving that area. A negative changes in mood and thinking. A lot of this comes from, usually it's our closest family members that notice this. It's not necessarily people that we always work with. But you could be one of those most optimistic people, and then you have a change in your behavior, and people are starting to notice that. That's post-traumatic stress as well. And when I talk about arousal symptoms, I think sometimes people take that a different way. I'm not talking about arousal symptoms from sexuality. This is more about hypervigilance. So, you get home, or, you're always kind of watching your back, or you can't relax. Hypervigilance, arousal symptoms can be, you get home and someone's like, well, what do you want for dinner? And you're like, I don't know, you decide. All of those things are basically, those could be post-traumatic stress symptoms. So on your screen here, and I think probably a lot of you probably have your phone or beside you, I always recommend people to take that number and put it into their phone, the Suicide Prevention Lifeline, the 1-800-273-TALK. You don't have to be suicidal to use that. You can just be in a crisis moment, and they're available 24/7. And so a lot of people ask, like, oh, well, is that a resource that will be close to me? So actually, when you dial that number, if you're having a crisis incident, whether that be yourself or for a colleague, they will actually basically triage to the nearest area that you're calling from and help you find resources eventually. So I see that there's about 59 of you who are on live right now, and it's kind of a staggering statistic that 1 out of 20 of you in this webinars basically have had a suicidal ideation, if you look at the statistics that way. And that's okay. That's actually quite a normal reaction. It's when people act on it that's an issue, obviously. So they're saying that in the general population that usually about 112 people per day take their lives. That's just in the nation. And just know that a lot of these statistics do not include law enforcement, nurses, docs, etc. And also anybody who's taken statistics know that statistics are usually 5 to 25% underreported. So what is ideations? When it comes to suicide, it's just having that thought. It could be once, it just passed through your mind, like, oh, my family would be better off with me. That's a thought, that's an ideation. An attempt is basically somebody that has acted on it, but they weren't successful. That's a huge cry for help, and that's something that we really need to pay attention to. So the CDC was reporting that in 2012, 0.5% of the U.S. adult population had attempted suicide, while 3.7% of the general population had contemplated. Now, in comparison, you'll see in the next bullet on the slide, and where I get these statistics from, and I have to give credit to Reviving Responders, they did a survey that went out in 2015 to EMS respondents across the nation, and I believe there was like 4,029 respondents to this. And they found that 37% of EMS respondents contemplated suicide, and 6.6% had actually attempted suicide. So if you actually do the math of that, that works out to about 260 individuals in our EMS community that had attempted suicide. To me, that is staggering numbers, and that's very, very eye-opening. So let's just kind of look at the statistics. From that survey, they found some really great insight. And so as you see, there's a graph in front of you, and you see that there's no encouragement or support, and you go to the right of the graph, and there's full support and encouragement. So on the survey, they said, do you have support in your institution when it comes to dealing with stress, or if you were suicidal or had contemplated? And 56% of them said they have no encouragement or support. 23% of them had full support and encouragement. So as you can see, even just bringing in peer support into your organization can help decrease the percentage of the chances of somebody acting on suicide. Suicide attempt. So 12% that attempted suicide said they had no encouragement and support. And again, to the right of the graph, 4% had full support and encouragement. So you can kind of see the theme and you can see where we're going with this. So what's going on? So I have spent probably the last 2.5 years really digging into the literature and the research and being part of forums and social media and just kind of really listening and hearing the themes of what people are talking about. And so I basically just bullet pointed of what I found in some of it. And some of the factors of what's causing all of this suicidal ideation and depression and PTSD is that there's anger. There's a lot of emotions that people don't know how to deal with, and whether that's, they're angry with the job that you're in or the way things are going, it's very individualistic. There's definitely a lack of empathy that's starting to occur, and again, that can be just one of the symptoms that can happen from post-traumatic stress. It's not because as healthcare providers, don't love what we do. It's just you get drained and you spread too thin and you lose that empathy. Repeated exposure. So this is one thing I've had discussions with a lot of my colleagues. At what point does our brain say, no, we can't handle this anymore? A big comparison that I view it as is we know concussions are concurrent. You can only get hit in the head so many times until you're going to have brain damage. At what point can we witness and experience the things that we do as healthcare providers and not have an effect on us? We know it changes you. And then the witnessing, a good example with that is when I was a flight nurse and I would be on scene and you have your California Highway Patrol or Nevada Highway Patrol or law enforcement, and they're sitting there and they're watching us, doing an intervention, life-saving intervention on a patient. And sometimes I would look back and I would just see this deer in headlights in their eyes. That's witnessing. And so, there's a lot of people who are around when we're doing the things that we're doing who will take it to a different context that we will. People are starting to social isolate themselves. And what I bring up on this and some of the research that I found is that as much as we love our 12-hour shifts that we're doing in the hospitals, it's actually doing a detriment as compared to when we used to do the 8-hour shifts. And why that is because after an 8-hour shift, people would actually go out after their shift and talk about things, whether over a beer or coffee or tea. After a 12-hour shift, people are exhausted. They just want to go home after, so they don't have that time to actually debrief. So you get more of the social isolation that's going on. Now, incivility, workplace bullying, and mobbing, I could do a whole webinar on that, and there's a lot of stuff out there, but it comes down that we are not really nice to each other. We're not supporting each other the way we can. There's a lot of incivility that's going on in our healthcare industry, and that's a big factor, and there has been known cases of people leaving the workplace because of this and even acting on suicide. So again, we need to take that collective consciousness and come together and try and prevent that. There's reluctance as failure, and the big issues that I'll kind of tap in on is that there is actually a lack of support. This is from peers, administration, and our organizations as a whole. And it's not that we fault them because they don't want to be. I just don't think that they truly know the resources that are there and how to go about it. And then substance abuse. So, what do a lot of our colleagues do and ourselves when we're stressed? They go out. They might have a binge drinking. It can turn into something instead of having the nightly glass of wine or whatever. It turns into 3, 5, 6, whatever that be. That's substance abuse. And financial stress is a huge one, and especially with the changing the economy. And compassion fatigue, again, we're doing these long hours, you're doing the overtime, some people are mandated to do overtime shifts, you're going to get compassion fatigue. And burnout syndrome, anybody who does, say, an assembly type of job can get burnout syndrome. A lot of people, how they deal with this is that they'll go on a little vacation after and they'll be basically replenished when they come back. But these are things that you have to be aware of. So what are some of the hot topics? Okay, so I'll go into a little bit more about being targeted. And actually there's some interesting research living at altitudes. Since I've spent a lot of my nursing career living and, having my office in the clouds, altitude physiology has been a part of the way I look at patients, and I live at 7,200 feet, so it's pretty interesting. And then increased suicidal behaviors and second victim syndrome. So how are we being targeted? I don't think I have to really go into too deep and explain what this is. You can see that media has done a perfect job, unfortunately, of showing how a lot of our healthcare responders are being targeted, and there's increased incidence of violence against those that are caring for others. I've read stories, I've seen, in a lot of our peer magazines, physicians going out to their vehicles, and because they didn't give that certain patient what they wanted, narcotics, that they've been targeted, either they, assault them or, hold them at gunpoint. I've had EMS providers being held at gunpoint because they're tending aid to a gang-related victim. Those are examples of being targeted. So we do live in a different world, and I just saw that there's definitely some stuff going on in Ohio with some shootings, and sending out a lot of love and light for those people who are dealing with that right now. But again, everybody experiences this targeted feeling. And again, that's going to cause a lot of hypervigilance that's going on. So living at altitudes. So for some of you that live at sea level, you might be asking yourself, what does this have to do with anything? But just know, as a quick and down and dirty, your first 5,000 feet of altitude gain is where you're actually going to have a lot of changes on the physical components on the body, on yourself or your patients if you do that. So they're finding some research that high altitudes might actually be linked to suicide risk. And for an example, if you look at the map there, everything in the dark orange is known to be in the suicide belt. And so because I live in Nevada, I use that as an example. Basically, anybody at altitudes, you look at Utah, Colorado, they have higher suicide rates, unfortunately. And what they're finding is that there's a metabolic stress that results from insufficient intake of oxygen. So basically it's aggravating. And so if you're somebody that already struggles with mood disorders or depression, this can aggravate it. So I kind of looked deeper into the research. I'm like, well, what's going on here? And so there's some great research done by Kim Choi and Lee in 2014. And they were suggesting that the serotonin synthesis is influenced by mild hypoxia. So there's an enzyme called tryptophan hydroxylase. Try and say that 10 times fast. It's actually a rate-limiting enzyme that the serotonin synthesis reaction uses. So with that enzyme being affected, the low brain serotonin is known to be associated with suicide. And so there are actually some research that they're replicating, and obviously in some rat studies, and they've done stuff in the Vietnam mountains, and they're finding a lot of the same stuff. So I will be following that and seeing if there's a correlation. And just seeing also what's happening up at Lake Tahoe. We have some high mountain communities as well, and there's definitely some increased risks of suicides that are occurring up here as well. So I just want you guys to take a moment to think, looking at that picture or thinking of a colleague. Just imagine your coworker or colleague is standing on the Golden Gate Bridge and ready to jump. Do you know what to say to them? How does that sound? Do you know how to keep them safe right now? Do you know how to keep that guy safe? And I bring this up because as healthcare providers, we're so good at taking care of our patients, but what happens in that moment that you're getting off shift and you're walking out to the car and your colleague says, you know what, I just can't do this anymore. I've got this going on. I want to end my life. Do you yourself feel that you have the skills to help that person, to keep them safe now? You're not there to solve their problems, but I bring this as an awareness because there's actually a lot of great workshops and applied suicide intervention skills training out there that can aid you in doing that. And even that one last slide that I showed you about the Suicide Crisis Lifeline, having that in your phone, even if you don't know what to do, you could be like, you know what, I have this great resource, let's dial this together and let's talk to somebody. That could be a big life changer right there. So I want to talk about second victim syndrome. You know, some people says that sounds really new to them, but it's not. It's been happening. There's a interesting, pretty high-profile story, and Kim Hyatt, who was an RN up in Seattle, in 2010 had dispensed 1.4 grams of calcium chloride instead of the correct dose of 140 milligrams on a pediatric patient. I believe the pediatric patient was an 8-month-old. And she immediately admitted it. She logged her error, like any good nurse would do, right? Because we're all about autonomy and self-reporting and accountability to our license. And she said, you know, I can't believe I did this. She had been a nurse for 25 years, excellent track record, never made a medical mistake. This was her first time, and she was talking to someone while drawing it up, and she miscalculated. So that's an awareness. It doesn't mean, you know, if you're a new nurse or a new healthcare provider or anybody that's dealing with medications, that this can't happen to you. You're not immune to it. So unfortunately, she was put on basically administrative leave, and then probably a couple weeks after that she was fired. And the Board of Nursing had put her on a probationary period, and the stipulation for 4 years is that she had to have somebody witness her giving medications. Well, as you know, what organization is going to hire another RN to oversee you give medications? So unfortunately, she died by suicide. Just because she could not handle that. She just didn't want to be much part of that. So I don't use this as an example to shame an organization. I use this as an example as an awareness to ask yourself, what in your institution do you have as a good safety culture? So just kind of touching on what a little bit of a second victim syndrome is defined. It's basically an unanticipated adverse patient event, and it can happen from a nurse perspective, RT, social worker, nurse. Usually that person, the second victim, feels personally responsible. Even if you have that safe culture, you're still going to feel really rotten about what had occurred, and it's going to carry with you unless you deal with it. So the onset, these are just some of the things. You might feel singled out or exposed. If there's a culture that you're worried about losing your job, maybe that person's not going to self-report because they don't want to lose their job. So there's so much that's intercorrelated with this issue that we need to be aware of. Later, the event's going to replay itself over. So you go back to our post-traumatic stress slides. What is that? You're having avoidance, you're having intrusive thoughts, all of this stuff's connected. So the facts. So they found that many clinicians still regard patient safety events as a personal failing under themselves, other than a system-wide issue. And there was some research that was done at the Missouri Health Center, and they found that 1 in 7 staff members will report an internal patient safety culture they had experienced within the past year. And from that, they had a lot of anxiety and depression, concerns about ability to perform their job. And they found that 2/3 of these clinicians reported that they did not receive institutional support. So just a reminder, and for some of you out there that you might not know, there's actually a Patient Safety and Quality Improvement Act that was done in 2005. And this act was enacted so that we can reduce the name, blame, and shame game in organizations. So just know that there is that support, and if you feel that you don't have that patient safety and quality improvement support in your organization, maybe just do a gentle reminder with that. A true test of patient safety culture, though, comes immediately after an event. I must say I've been very, very fortunate to work in some really great organizations that have embraced this, and I'm pretty proud of them for that. But that might be something that you might want to have to ask how your institution is handling that. So let's look at some of the suicide statistics of firefighters and EMTs. I have to give Captain Jeff Dill, who's from the Firefighter Behavioral Alliance, he's taken upon himself to actually track these, and he's gone back as far as the 1880s. I just checked last night, and unfortunately for 2016, we're at 111 suicide deaths from firefighters and EMT, and most of them are firefighters. So He's not tracking this stuff as to be, morbid. There's no specialized organization that's tracking these. And he's tracking these to try and trend of, like, what can we do better in this environment to improve, taking care of our healthcare responders, taking care of our heroes, right? So, and he was also finding, he has basically an anonymous reporting on his website. And so some people have anonymously reported, how they had acted on suicide. And probably not surprising to most of you, but most of them happen to firearms due to accessibility. And then hangings right up there. I always bring attention to the immolation because sometimes people don't understand what that word means. And that has to do with basically setting yourself on fire. So these numbers up here, these are all people that we have lost in firefighters and the EMTs. And then he even broke it down. Well, were these people active? Were they retired? And most of them are active. So a lot of it has to do with the stresses in their environment. Did these people have the support? You're starting to see more of awareness if you're on any social media and, firefighters taking their lives, paramedics. I've worked in institutions that, we've had paramedics take their lives, and it's sad because it really does affect the organization as a whole. So you'll look up here the police suicide rates that we have going on, and you'll say, well, some of them contradict themselves. Well, they do because, again, they don't have any one organization that's tracking these. And the sad thing with suicide rates with police is that there's some organizations that if that officer had died by suicide, then the life insurance would not cover and there wouldn't be that contribution to the family. So there's a lot of hush-hush with it. And so I like to look at the annual suicide rates of the 56 per 100,000 and comparing to the U.S. Army in 2008, they had 20 per 100,000. And the general public goes down to 11 to 100,000. So it's pretty staggering. It's big awareness that we need. Now again, there's actually a huge staggering number with the suicide for physicians and depression rates. And again, nobody is basically tracking this, but what we could find is that each year in the U.S., roughly 300 to 400 physicians die by suicide. So just think how many of our patients are being deprived by these wonderful primary care providers. And again, this is not something that's broadcast in the news. It's kept hush-hush. And why this is, it basically has to do because they know how to have access to greater lethality of drugs and easy access to means. Depression's been a major risk for them from what they found. And other factors is that there's underlying stuff. So they might have bipolar disorder or alcohol or substance abuse. And then what I found was pretty interesting is that medical students have rates of depression 15 to 30% higher than the general population. And I know that they're trying to change that and basically, skew down the amount of hours that medical students can work and train. So nurses, and I reach out to all of you on this webinar. If you know of anybody who's officially tracking nurse suicide rates, please email me and share that. I've had a hard time. What I could find is that approximately 8 out of 100 nurses are currently been using illicit drugs, and 9.6 of them have suffered at least one major depressive episode. They're saying that the attempts is 0.11 per thousand. And what I found was very interesting is that female nurses 4 times more likely to act on suicide than other women. And that could be a varying factors. A lot of nurses, their mothers and their career, and they do have a lot of stress on their shoulders. So what can we do is a big question that came up. And I'm like, I've gone to a lot of talks and webinars and seeing some great talks, but I felt walking away from a lot of them that there was not really necessarily the down and gritty of resources available. So the big thing that you want to take away today is start paying attention to one another. Check in with each other. We want to build this community of mental resiliency instead of breaking each other down. Support is huge. And I must say that, as much as, social media gets a bad rap, It's also a great resource. I know that I've been able to reach out and help others on social media by just kind of monitoring posts. And you can see that somebody who's always posting really great things, and then they might have this like very skewed random post, and you're like, that's just not like them. I'm going to check in with them. And usually my intuition's been pretty good, and I've been able to assist them in getting them resources that they need. So 4 steps to help a distressed healthcare responder. If you look at it, I kind of envision it as like the Infinity 8. So this is not a linear process by all means for anybody, but we want to help either yourself or your colleague to recognize the problem. And whether that be depression, PTSD, suicidal ideations, it's very individualistic. And we want to help them plan the intervention. Sometimes it's making that first step to get help, and we'll talk a little bit more what's available out there. And then completing the intervention, going through with it. And I'll tell you from the research that I found, involving family members in completing the intervention has increased success rates for people getting better. And then the support, that's a continual thing that goes on. So what does it mean to build mental resiliency? So currently in my master's program, I'm actually working on building a 4-hour workshop on how we can build this for our healthcare responders. And it's been very interesting because there's not really a lot of stuff out there that says, okay, step A, this is how you build mental resiliency. But there's definitely some themes, and part of that is building a sense of community. Collective efficacy, being self-efficient is huge. I'm a big promoter of, pet therapy or emotional support dogs, and there's some great research happening with that. I'm not going to, sit here and tell you, you should have a good diet and exercise. The research shows that we are actually doing a really good job at exercising because that is a coping mechanism, but just make sure you're paying attention to eating the right things or not skipping meals and trying to normalize that. Compassion, satisfaction. So do you have that in your job? Is your organization working on that? I know we did a series at my organization where they had built in a compassion satisfaction for our staff, and there was some really good feedback from it, and it's nice to see that was happening. And then resiliency training, good examples, you look at the Navy SEALs, and a lot of that comes down to having a good mental forethought, being aware of those negative thoughts that come through your head and going through. And just having self-awareness, that's kind of a common theme that I've talked through this webinar, but just being aware of what's going on with you or, someone around you. And I really like the Manner Psychological First Aid because they break it down, and what that stands for is that they want to minimize the exposure, and if you are having a critical incident, acknowledge the event. Don't brush it under the carpet. Normalize the experience. That's the whole thing that we want to do, is reduce the stigma. And then educate where required, and then we want to restore and get self-care. All right, so interventions for heroes, that's all of you out there. So being on a critical response team as a peer support member, I'm a huge promoter of critical incident stress diffusings and debriefings. But what has happened out there is that a lot of our organizations have either not paid attention or put the effort into developing proper teams that have proper training. So they don't work when you put people into these, CISM teams who have no training and being able to do diffusings and debriefings. But when you do have a team that's trained in this, it's actually really effective and you have really great outcomes. And I've been honored to be part of some of these really big critical incident stress debriefings and diffusings and seeing how people have embraced it. Having peer support is huge. Your family support, include your family. You don't have to tell them about the bad calls or the cases that you've done, but they want to know, they want to feel empowered of how they can help you communicate that. So there's a really great book called Bulletproof Spirit, and what they found in there is that empowering the family members created much more success, like I had just said. There's mental health first aid, and then I talked about early in this webinar the applied suicide intervention skills and training, and that was a great 2-day workshop. Even though I'm a survivor child of my dad dying by suicide, I have the life experience, but I never had the formal training on how to help somebody with that. So it was quite an honor to do that. There's cognitive behavioral therapy out there. There's something called timeline therapy, which is done by humanistic neurolinguistic psychology, and it's a lot like the EMDR below there. the eye movement desensitization or reprocessing. A lot of law enforcement is using that. And what's great about that, it's not your typical psychotherapy session. It usually takes about 90 minutes, and then there's about three to six sessions is kind of the norm of what EMDR does, and that has really helped people who are dealing with post-traumatic stress. There's the bestow philosophy beyond survivor toward officer wellness, and there's TRE training, which is tension and trauma release exercises. And I compare that to a lot of like progressive muscular relaxation. If any of you have heard that, you can get these scripts online for free. You know, that's another way to deal with what's, you know, stressful for you. And then spiritual wellness. You know, that doesn't mean you have to go to church, but believing and having faith and hope, that's a huge part of spiritual wellness. And then again, you see pet therapy. And sometimes if these things don't work, it might be worthwhile to do a career change. So my story, you know, people always kind of want to know that. Well, I was 7 years old, and it was Easter weekend, and my mom, and she was pregnant with my sister. We had went out to my auntie's for Easter weekend, and we're all getting ready to sit down for dinner, and we got that phone call. The phone call was my dad on the other line, and of course, as a 7-year-old, could definitely stress something was going on. And that phone call was what my dad did to say, you know, he was sorry and told my mom, you know, he's going far away, that no one would see him again. And that he says, you know, he just wanted to know that he loved us very much, and, you know, that was his way of dealing with stuff. My dad wasn't an aggressive person by any means. You know, his mode of suicide was carbon monoxide poisoning with the garden hose on the back of the truck and sleeping pills. So that was his method. But he had dealt with his own demons and depression, and but he was always the life of the party and loving person, and, you know, that's how people remember him. So I want to talk about that every 15 minutes someone in the U.S. dies by suicide, and every 16 minutes someone's left to make sense of it. And it's a lifetime of making sense of it, let me tell you. So what about those who are left behind? We actually, survivors of suicide, represent the largest mental health casualties related. You know, again, going back to the stats, over 41,000 annually in the U.S., and they're estimating that for every suicide, there's at least 6 survivors. And we know that there's more than that, but that's what they're correlating. So what do feelings of survivors feel? Well, you feel everything. Everything from stress, denial, guilt, anger, despair, disbelief. You pose questions, what could I have done better? You know, you're quarterbacking, like what could you know, was there signs? Did you see anything? You definitely beat yourself up. And, you know, it's very individualistic for the person that chose to end their life by suicide. And sometimes you'll never have those answers. And you just kind of have to grow, you know, and move on with life, and it makes you who you are. The whole adage, you know, time heals, well, yes and no. I think that it does heal, but like I said, it changes who you are. So here I am today talking about that and being a voice for others. So children do grieve, and I bring this up just because, you know, I don't fault my mom on it, but when I was younger, she had told me my dad was in a truck accident, which, yeah, kind of true. But guess what? You go to school, you're in a small town, kids talk. So how did I find out how my dad really died? By a kid at school. So children are very vulnerable to feelings of guilt and abandonment. Secrecy in hopes to protect children actually causes greater complications in the long run. So you want to basically explain honestly with age appropriateness. You don't have to give them the gory details, but you want to be honest with them. They're smart, and especially, you know, look at in this day and age, everybody has access to social media and the internet. You know, I didn't grow up during that time, but I can only imagine how it would be today. So the great thing, which I didn't have growing up, there wasn't the great resources, but there are. There's survivors of suicide kits, coping handbooks, healing. There's actually conferences, you know, and then counseling, which I basically had access to the counseling, and, you know, it was definitely beneficial. So in summary of what's needed improvements, and then this literature comes back to the Reviving Responders survey. And what they had found that 16% of respondents found that having an appropriately trained counselor or therapist when it came to CISM improvements was important, which I had talked about, and then having more visits available. And then some people just don't like being in a group setting. So just know with CISM situations, you can do more intimate sessions. It doesn't have to be in big groups. And then when we're looking at private therapy improvements, again, 41% saying they want an appropriately trained counselor and therapist. And it was great finding this data because I had people that had shared their experiences going to counselors that had no idea what we do as healthcare responders. And one person had told me, yeah, they went to this counselor and had shared basically their deepest, darkest secrets and their craziest calls and the ones that were bothering them. And the counselor sat across from him and said, I don't know how you guys do it. So how does that make that person feel sitting across somebody who's supposed to be there to help them, to help our heroes? So employee assistance programs, this is probably one of the most underutilized resources you guys have out there. Use it. Trust me, your work will not know that you're using it. You pay for that in your insurance. That's anywhere from $400 to $600 of services you're paying for, you guys. You know, but when you do call and you want somebody who's a counselor to deal with your post-traumatic stress, it's okay to request somebody that is trained in trauma counseling, because that was one of the feedback they came back as, again, having an appropriate trained counselor or therapist, and then having more visits. So the people that have utilized their EAP programs realize, like, oh, great, this is a great service. So symptomology, you know, that's a big word. This is basically just an agreement between you and your patients. So as a provider and a responder, if you're not well, how can you take care of your patients? Are they getting the care they deserve? And are you totally present when you're distressed and you're not in your right mind? We actually have the ethical duty to ourselves and our patients. And so I just kind of bring this up, and I'm not big on like fear-mongering or anything like that, but again, it's just having that self-awareness. If you're not in your right mind, how can we take care of our patients and give them the optimum care that they deserve? So we want to advocate for them. We want to avoid negligence. As you know, we live in a very litigious society, and we don't want to set ourselves up for, you know, a negligent or a malpractice suit. I can tell you from being a legal nurse consultant and, you know, being involved with cases, you know, I've looked at these cases, I'm like, they just missed that one important thing, like, and it seems so simple, and of course it's always easy to quarterback, but then I always think to myself, I'm like, you know what, there must have been something else that's going on, but as you know, the electronic medical health records never paint that picture that that person just had a bad call before that, or had a bad patient that came through the ED, or it was chaos, or they were low staff that day, and that's why they forgot to do that. So just take care of yourselves. You know, again, we want that duty to act, and if we breach that duty, then there can be a cause and effect, and that's when damages occur to our patients. So just a word of caution, again, you know, if you're not going to take care of yourself or your colleague, you know, maybe that motivation to make sure that we're doing that for our patients will help us get through it. So on the screen, you'll see there's tons of stuff there, and there's even more. And if you're big in social media, Code Green campaign has done some great awareness, some forums and talks, gets people talking about it. There's the Badge of Life. If somebody's interested in doing, you know, getting a peer support team going, that K-Love, if you go on their website, they provide free training for organizations that want to, you know, put together support teams. They do that because they get a lot of grants and donations, and they know that a lot of the medical community can't necessarily afford or have the budgets to encourage our mental health programs for our healthcare responders. So yeah, and then there's that Bulletproof Spirit. You know, there's a lot of great stuff out there that's available to you. So that brings us to the conclusion of our webinar. If I don't get questions or your questions answered today, you know, I'll get back to you. You can email me at either one of those emails there. This is just the tip of the iceberg. it's, 50 minutes. There's just so much out there, and I'm excited, and I'm hoping that, this does a little spark for the rest of you to get things going where you're working. So I'll bring that forward to Cody.
Thank you, Natasha. We currently have a couple of questions, and as a reminder, if you have any questions for Natasha, please type them into the question queue, and we'll get to them if we have enough time. The first question, what should one do if they have depression in their medical history and are in a workplace where they're being bullied and their depression is being exacerbated?
Oh, that's a pretty loaded question, and it's very, very different on every organization that you work on. If that's something that's like they've gone to their manager or their director or leadership and things haven't been dealt with, it's hard because you become that target, and of course people talk about that person. That really does come down to an HR situation. And I know in my personal nursing practice I have zero tolerance for bullying, and if I witness behaviors like that, I will be that person to intercept and say something. But you don't always have those people who feel they can have that voice because they might have fear of retaliation. So my biggest recommendation would be definitely go to HR if that's a common theme. And if that doesn't work, perhaps, like I said, working with like your EAP program, they have access to not only like counseling, but if, you need direction in that area, they might have some great resources for that. But yeah, I wish I had a black and white answer for that, but I would say definitely, work with HR on that.
Thank you. The next question, looking back now, do you wish that your mother would have told you the truth from the beginning?
Yeah, I do, and it's interesting that you asked that question because it did. It really did harbor our relationship and that trust, and finding out, and of course, she was just doing what others had told her, and of course she had never dealt with that, and it was a protective mechanism, and I don't hold, anger to her for that, but yeah, in retrospect, because I'm all about truth and honesty and transparency. But it probably has to do with, stemming back to that situation.
Great, thank you. And I also had a question if the resources, the resource list will be available for this presentation.
I believe if it's not attached to the PDF in your handouts, email me. Yeah, there it is. The reference is right there.
I just added it.
It should have all of that.
If you go to the handout section, you'll be able to download the PDF of the slideshow and also the references. A next question, could you briefly describe EMDR, please?
Yeah, so EMDR, like I was saying earlier, there has to do with it's basically, so anybody knows if you're doing brain-based cognitive therapies, your eyes have a connection to the brain, believe it or not. And so eye movement desensitization or reprocessing, it's a psychotherapy treatment that's originally designed to alleviate distress associated with your traumatic memories. And they've actually done a lot of research. So you would probably just go in for a session and, I don't like to use like hypnotherapy or anything, but it's a counseling session. And they're going to basically touch in on the triggers or the stress that's occurring with you. And that counselor, that psychotherapist is going to walk you through on basically how to reframe that and reprogram that situation that you're viewing that has such an impact on you. And so it's highly, highly effective. And usually, you start off as like a 90-minute session, and they have a few phases they go through. So your first phase, they're obviously going to explore what's going on with you. And then when they go into the next phase, there's, that's when they start getting into the treatment and basically different ways of handling the emotional stress. So it's a technique that will allow you to have resources and tools to deal with whatever it is that you're dealing with. And a lot of the research they're doing now, they're finding people are becoming cured from their post-traumatic stress from doing that therapy.
Great, thank you. And it appears we're out of questions. So again, if you have any questions for Natasha, you can email her at the email address provided on the screen. And you will be receiving an email within 1 hour with a link to the survey you must complete for your continuing education credit. And thank you again for joining us for today's webinar. Have a great rest of your day.
Thank you, everyone. Take care of yourselves out there.